Hi, my name is Dr. Eric Brink. I'm the new trauma medical director at Camp Lejeune. I started here just at the beginning of April, so I've seen quite a few of you in several of the activations and kind of a face floating around amongst the crowd. Captain Perkins has gone on to Pendleton in California, so I am the replacement for that. And the position used to be the XO, or the second in charge in the hospital, as well as in charge of the trauma program. And since her departure, I've taken over the program completely. That's my 100% job, and the XO has gone back to being a full-time job in and of itself. That being said, you'll see me around, I'm sure, in the future, and with future activations. I'm usually somewhere in the vicinity. A little about myself. I'm kind of a Midwest boy, born in Nebraska, Scottsbluff, Nebraska. Parents migrated out to Oregon on the Oregon Trail. Wasn't quite back in the 1800s, but grew up for the most part in Oregon. Unfortunately, I've been a Husker fan all my life. Not always a pleasant life to live when you have teams like Oklahoma and Miami, Colorado State, University of Colorado. I could just go on and on. The Hawkeyes, etc. So it's been a humble experience in my life being a Husker fan. You can rib me about that when you see me in the future. I went to school in Missouri, medical school in Missouri, northern Missouri. I did my residency in Pennsylvania, so my general surgery training, and a lot of my trauma experience comes from shock trauma in Baltimore. I spent several years in shock trauma, going back and forth from Pennsylvania over the border. It was about an hour drive. I would work 2 to 3 days at a time and then head back to Pennsylvania. I did that for about 4 years. Once I graduated, I ended up over in Okinawa, Japan, which is a kind of an unofficial Navy trauma center. We took a lot of Marines. We call them bored Marines because they find ways to injure themselves. One of their favorite injuries was they would drink quite a bit of alcohol on a Friday night. The barracks were often lined at a 90-degree angle where the corners would touch, and they would climb to the 3rd or the 4th floor and see if they could jump from building 1 to building 2, window to window. Several of these individuals missed the jump and ended up on the ground. So I found myself in the middle of the night many times treating fractured pelvis and backs and necks and liver injuries and such. You know, you've seen it all. Okinawa was a great springboard for me to go to San Diego at Balboa. I was teaching staff there, but I was a full-time trauma surgeon in Orange County at Mission Viejo Hospital there. And we took about 3,600 traumas a year. It was a level 2 trauma center. I stayed pretty busy there. At that point, I decided to go to Naples, Italy. Italy was kind of a quiet little rest after being a full-time surgeon in Southern California. And there I was, drinking my wine and eating my pasta when a phone call from Captain Perkins came to me and asked me to be the trauma medical director here because of some of my trauma background. So here I am. They broke my orders in March. I actually flew out of Naples March 29th. I checked in March 30th, and I was immediately starting work on April 1st, and I've been here ever since. So that's just a little bit about me. I'm trying not to bore you too much, but I enjoy trauma. One of the reasons we're doing this talk is kind of what I wanted to do is kind of connect with you. I wanted to first thank you, our EMS brethren, for all you're doing. The incredible response times as you continue to improve, your quick assay in the field, recognizing injury patterns and such. I've been so impressed by the professionalism coming into the ED, the reports that are given, the care that you've given the patient in the field, and then the transfer of care to us to then progress along the patient's triage. My hat's off. You see a lot in the field. I know that we have a very sterile environment here. We are used to our clean gurneys and our clean rooms and our clean operating rooms, and you guys are out in the dirt, in the fields, and on the side of the roads. And I really appreciate the work that you're doing. And you don't often get thanked. So officially from the Trauma Medical Director of Lejeune, thank you. Thank you for all that you do. As the Trauma Center, they're really starting to look at us, and you're part of that. You are our part of our platform, part of the foundation of this program. Dr. Toshlag up at Vidant and I are working on a program right now. We're looking at Onslow County. We're looking at the 5 surrounding counties that we also kind of contribute to, but specifically Onslow. We're looking at the reduced morbidity and mortality, the reduced consequences of some of these injuries within our county. Originally, before the Trauma Center, as you know, we had a fairly high morbidity, mortality, not to anything that contributes to EMS, but just for the fact that there wasn't anywhere to bring them other than an hour or greater than an hour transport time. One thing the Trauma Center has done here is we've kind of given Onslow County that platinum 15 minutes. We always talk about the golden hour, but the platinum 15 minutes is the faster you can get them to us, the faster we can triage, the faster we can take care of the patient. And so what we're starting to see as we do the studies within Onslow County is we're starting to see that morbidity and mortality go down. We're starting to see increased survivability. We're starting to see patients who should have died but didn't, and they're walking away. And that's thanks to you and thanks to our partnership. So I'm really proud of some of the things we're doing here. So you might ask, what are our capabilities? A lot of people throw around, you're just a level 3 trauma center, just a level 3. What does that exactly mean, level 3 trauma center? The level 3 trauma center basically means we don't have a neurosurgeon here or a spine, and we are working hard to get that coverage while we're here. But recently we have now received a trauma orthopedic surgeon, which is great news. So Dr. Lewandowski is here now, and he has already started operating some of the complex femur fractures, the complex tibial plateaus, the bad ankle fractures, even some of the pelvic fractures we can now take care of here at Camp Lejeune without that having to ship. I'm also actively recruiting an interventional radiologist. What that does is that allows us to do some interventional procedures, embolizing spleens, embolizing pelvic fractures, and actually keeping some of these higher injury severity scores at our institution. That makes people of the county able to stay close to home rather than these long drives that they have to do to Greenville or to Wilmington. So basically at this time, what I'm trying to say is we can handle basically everything that's not a brain bleed or a brain injury. And I encourage, bring it all to us. Bring it to us. I know you have your discretions in the field, but we're making some great forward strides in the injury scores that we're taking care of here. We just were up at ERAC, the Eastern Regional Conference, with Vidant last Friday, and they're reporting that our injury severity scores that we're transferring up to Vidant are 22 and greater. So we are keeping everything that is 21 and below, and that's a huge stride for us, because it used to be injury severity scores of 5 to 10. What does that mean? That means single system injury getting shipped, everything getting shipped, a spleen getting shipped. Now we're keeping things like that here. So our injury severity scores that we're keeping are going up, and our transfers are really necessary transfers that need to go to a level 1. That being said, what I'm looking at is how can we be better? What process improvements can we do together as a partnership? One thing I'm concentrating on is something called under triage rates. And I know you know a little bit about this being in the EMS field. But they're looking at our under triage rates as our institution right now. And what we're finding is that we're quite a bit above what we would consider to be ideal. We're supposed to shoot for an under 5% under triage rate. What that means is a patient meets trauma criterion. We don't call the trauma level. Patient shows up here, never gets called a trauma, is then triaged in every which way or so, but probably should have been treated by the trauma team. And so either a level 1 or a level 2 trauma. And so what we're trying to do is really concentrate on the trauma criteria, calling the traumas as they are. And so, as you know, at our center, we have our level 1 and our level 2 trauma criterion. What we're trying to do is make sure that the appropriate level is called. One thing we're noticing is that, say in a pretty good accident, I think we had the other day, small car versus big truck, obviously we see hundreds of those a year. Patient was kind of unresponsive on the scene, but came to, was able to, I think he was laying beside the car, and they basically came on, found that his systolics were 80, 90, and then with a little bit of saline and some IV fluid, pressures improved. And so he was called to level 2 and brought to us. But one thing I want to concentrate in is that we're really concentrating on the lowest systolic pressure at any given time during transport. So rolling up on the scene or finding a patient who drops their systolic during transport under 100 qualifies as a level 1 trauma rather than a level 2. Now, you may have brought them to us with a systolic of 100 or 110, and that truly would qualify as a level 2. But if they drop that systolic during transport, that's very important for me as a trauma surgeon to know. One, we upgrade that to a level 1 because it brings our blood bank in case the patient needs transfusion. It brings our OR on standby. It brings our anesthesiologist down. It puts our CT scanner on standby. So there's multiple mechanisms that now go into place when we upgrade to a level 1. Literally, it brings everyone from the house down to that area. For me as a surgeon, now I know with a drooping systolic that I need to be looking for injuries that are viscous injuries, what we would call solid organ injuries, bowel injuries, spleen injuries especially. So it just kind of gives us a little bit more leeway and time, kind of a heads up prior to that patient's arrival, so we can plan appropriately. So that's one thing I've really wanted to concentrate on, is any droop in the systolics under 100 that kind of meets our level 1 criterion, don't be afraid to call that. That's the next point I wanted to get to, is don't be afraid to level a trauma. I am specifically looking from our institution, I don't want them talking you out of a trauma criterion. Part of that, the alert criterion, is paramedics' discretion. And I want you to utilize that. That is not something to be afraid of. And please let me know if you're being given a hard time because you feel like a trauma should be leveled and it is not. That is your priority in the field. I'm not there. A really good example of this is we had a ground level fall from a Walmart. Level 1. You know, I heard the ER doc on the phone trying to talk EMS out of leveling it as a level 1. It was a geriatric ground level fall. But you brought me the footage from Walmart, and I saw that the patient not only did a ground level fall, but he was trying to stop himself by stabilizing on the shopping cart. Instead, not only did he fall, hit his head, have a brain bleed, but he dragged the shopping cart over onto his face and had multiple facial fractures as well. Had I not seen that video from the Walmart, we would have treated it as another ground level fall. So I appreciate that you stuck by your guns in the field, knowing the full extent of those injuries. So I appreciate that. Please don't let us talk you out of a level trauma. I think there was one more point I was going to get to. When you come into a room and you're giving a report, I know I hear sometimes that they're not listening to you, or that the surgeon, or they're busy, or they jump onto the patient right away. I'm really trying to put emphasis on slowing them down to listen to your story, to hear what you have to say, because it's valuable information. You will find, though, at some points where it truly is a crashing patient, CPR in progress, or a gunshot, that will often get to what we would consider business right away and not necessarily take the time to hear the entire story. What I would like you to do is keep giving the story to the room. You may not make eye contact with the surgeon, but in your strongest voice, please tell the story of this patient, because I have 3 nurses in the room who are recording all the information and everything. And as we are triaging the patient, we'll continually ask, now what was the mechanism, now what was the story, now what was the lowest systolic. That nurse will still have all that information because she will dedicatedly listen to everything and your entire report. So in those really bad situations, it may feel like you're not being listened to, but I'm usually in the room, as well as a trauma nurse coordinator and a trauma nurse recorder. So we are getting all that information belted out. Who cares if anybody is making eye contact with you? Just let her rip. And that's my 2 cents for that. I don't want to bore you. This has kind of been long, but I appreciate your time. One of the placards I always used to love at Shock Trauma used to say, you know, I can't save the world, but I might be able to save the guy in front of me if I can get to him fast enough. And you're the key to that success. And so I just want to say thank you for all that you do. Keep bringing us patients. Let's keep working together. Let's keep saving lives. We're making our county better. So I appreciate it. Thank you for your time.